A bicornuate uterus is a womb that looks like a heart, with two horns at the top. It happens when the two tubes, Mullerian ducts, that should join together in early pregnancy stay partially separate. Think of it like two balloons tied together at the bottom, instead of one single balloon. The resulting shape creates two distinct uterine cavities that share a single cervix, unicollies, or sometimes two cervixes, bicollies. This congenital anomaly is a structural malformation, not a disease, and it can be present without any symptoms. The problem starts in the embryo when the Mullerian ducts do not fuse correctly. Normally, by the 10th week of gestation, the paired ducts merge to form a single uterine cavity. If the fusion halts prematurely, a bicornuate shape results. This defect can be inherited. Families may show a pattern where a mother's sister or aunt also has a bicornuate uterus. It often coexists with other congenital malformations, especially renal agenesis, ureteral duplication, or vertebral anomalies, because the urinary and reproductive systems develop from adjacent embryologic structures. Because the uterus has two cavities, the myometrial muscle walls may not contract uniformly during menstruation or labor. The asymmetrical contraction can impede proper blood flow to the placenta and alter intrauterine pressure patterns, similar to a split road causing traffic congestion. The cervix may also be less efficient at maintaining a closed environment, potentially leading to early dilation. Hormonal signaling remains normal, but the mechanical environment for a developing embryo can be compromised, increasing the risk of implantation failure, miscarriage, or malpresentation. Only about 1 in 1,000 women have a bicornuate uterus, so it is rare. It is seen across all ages, races, and geographic regions. But the exact prevalence may be higher because many cases are discovered incidentally during routine pelvic imaging or surgery for unrelated reasons. Women may notice trouble getting pregnant, repeated miscarriages, or dysmenorrhea, painful periods. During pregnancy, the fetus may present in a breech or transverse position. Preterm labor is more common, and uterine rupture, although rare, can occur in late gestation or labor. Some women remain asymptomatic and only learn of the malformation incidentally during an ultrasound performed for another indication. Doctors first suspect the condition when a woman reports infertility, recurrent early loss, or atypical pelvic pain. A transvaginal 2D or 3D ultrasound is the first-line imaging test and can reveal the classic heart-shaped fundal indentation. MRI provides higher-resolution multiplanar images that confirm the depth of the fundal cleft and differentiate it from a septate uterus, which has a single external contour. HSG shows a Y-shaped uterine cavity, while laparoscopy or hysteroscopy can directly visualize the external uterine contour and internal cavity for definitive diagnosis. If both horns extend nearly to the uterine fundus, the anomaly is called a complete bicornuate uterus. When the fundal indentation is shallow and the horns are only slightly separated, it is termed a partial or bicornuate unicollies uterus. Some women have two cervices, bicornuate bicollies, which represents a more extensive duplication of the lower uterine segment. The depth of the fundal cleft, measured in centimeters on imaging, guides the classification and helps decide whether surgical correction is indicated. If a woman is asymptomatic, observation and routine obstetric care may be sufficient. For those experiencing infertility, recurrent loss, or malpresentation, surgical correction is considered. The classic Strassmann metroplasty involves a transverse abdominal incision, opening the uterine fundus, and stitching the two horns together to create a single cavity. Laparoscopic and robotic approaches now allow the same repair through small ports, reducing blood loss and recovery time. Hysteroscopic metroplasty can be used when a thin septum separates the cavities. A resectoscope cuts a small bridge of tissue to unify the space. During pregnancy, Cervical cerclage may be placed to prevent premature dilation, and close fetal monitoring is advised. Most clinicians recommend delivery by cesarean section, especially if the fetus is breech or if uterine scarring is present. Women planning pregnancy should undergo an early pelvic ultrasound to assess uterine morphology, particularly if there is a family history of Müllerian anomalies. Genetic counseling can discuss the modest hereditary risk and the possibility of associated renal or skeletal anomalies. Awareness of preterm labor signs and regular prenatal visits with a maternal fetal medicine specialist help mitigate complications. Most women with a bicornuate uterus can have a healthy baby, especially when the condition is managed with surgery or careful obstetric monitoring. Live birth rates are approximately 60 to 70% without surgical correction and increase to over 80% after a successful metroplasty. The risk of uterine rupture remains low, but is higher in untreated cases that progress to term, underscoring the importance of delivery planning. Advances in high-resolution 3D ultrasound and rapid sequence (MRI) now allow clinicians to map the uterine fundal cleft with millimeter precision, facilitating more accurate decision-making about surgery. Small prospective studies suggest that minimally invasive laparoscopic metroplasty yields comparable pregnancy outcomes to the traditional open Strassmann procedure, while shortening hospital stays. Molecular studies are identifying candidate genes governing Müllerian duct fusion, for example, HOX and WNT pathways, which may eventually enable prenatal screening or targeted therapies